Hello everyone and welcome to my Neuroanesthesia Rounds presentation. Today I'll be discussing the topic of airway management with a stereotactic head frame in situ. Before I begin, I just wanted to give a shout out and thank you to Dr. Noppins for helping me with this presentation. First, we will start with a little background information. Deep brain stimulator insertion is increasingly being performed at tertiary level institutions as a standard treatment for patients with Parkinson's disease and other movement disorders such as essential tremor. Often this is performed in an awake patient under local anesthesia and IV sedation as tolerated. The surgery involves placing a stereotactic head frame, which limits the anesthesiologist's access to the airway. CT-guided confirmation of external coordinates, microelectrode recording, and stimulation are used to test for accuracy. In reviewing the literature, there was not a whole lot available on this topic. I did come across a few case studies as well as older reviews on how to manage the airway in a stereotactic head frame, which I did include in the resources on my last slide of this presentation. However, we will be focusing mainly on this article that I found that was published in the Journal of Neuroanesthesia in January of 2018. This is a study based out of Toronto Western, and it is entitled Airway Management with a Stereotactic Head Frame in Situ, a Mannequin Study. Emergency airway rescue may be required in situations involving respiratory obstruction due to excessive sedation leading to unintentional apnea, secretions, bronchospasm, laryngospasm, or a combination of the above factors while the patient is still in the stereotactic head frame. This observational study attempts to analyze the time taken for emergency airway management in a mannequin with and without the head frame in situ. There are a variety of stereotactic head frames available. The most commonly used is the Lexell stereotactic system. This was invented by Dr. Lars Lexell, a Swedish physician and professor of neurosurgery in 1949. Dr. Lexell later went on to develop the concept of radiosurgery in 1951. The Lexell stereotactic head frame is the head frame that is most commonly used at LHSC. An important intraoperative concern for the anesthesiologist managing deep brain stimulator insertion is the need for emergency airway management while the patient is in the stereotactic head frame. This can be challenging due to a number of reasons, including the head frame providing limited access to the airway, as well as the head frame restricting neck movement. Removing the head frame is time-consuming, and if the head frame is removed, the patient must return to CT or MRI to reestablish the external coordinates before proceeding with surgery. Currently, there's no information in the literature about the ease of emergency airway management with a stereotactic head frame in situ. The goal of the study was to determine the ease of emergency airway management using an LMA and intubation with direct laryngoscopy and video laryngoscopy with the head frame in situ. The primary outcome was to determine whether the number 4 Portex LMA and tracheal intubation using direct laryngoscopy with a MAC 3 blade and video laryngoscopy with a CMAC 3 blade could be performed successfully on a mannequin with the head frame in situ. The secondary outcome of the study was to determine the number of attempts and time required for successful airway management with a number 4 LMA and tracheal intubation using direct laryngoscopy with a MAC 3 blade and video laryngoscopy with a CMAC 3 blade in a mannequin with the head frame in situ. This study was an observation study using a mannequin. The participants involved 30 anesthesia personnel from different levels of training. The stereotactic head frame was applied on the mannequin, simulating a real-life scenario. The participants were asked to first insert a number 4 LMA in a simulated surgical position facing the patient. The participants then intubated the mannequin using direct and video laryngoscopy. These maneuvers were then repeated without the head frame. The data collected included participant demographics, including years of anesthesia experience, the number of attempts for airway management, and the time it took in seconds to successfully insert the LMA or intubate the patient. The elapsed time was noted from the opening of the package containing either the LMA or the endotracheal tube until bilateral lung expansion. Results. This table shows the average time to secure an airway with an LMA and intubation with direct laryngoscopy and video laryngoscopy, both with and without the head frame in situ. With the head frame in situ, 97% of participants successfully inserted an LMA on their first attempt. Similarly, 93% and 97% of participants were able to intubate the mannequin using direct laryngoscopy and video laryngoscopy, respectively, on their first attempt. All the participants were able to insert the LMA and intubate the mannequin using both direct and video laryngoscopy during their first attempt without the head frame. This second results table shows the average time for residents, fellows, and consultants to secure the airway with the LMA, as well as with intubation using direct laryngoscopy and video laryngoscopy. The time to securing the airway was compared between groups of participants, residents, fellows, and consultants, because the level of expertise may affect performance times. It took residents longer to secure the airway using video laryngoscopy when compared with fellows and consultants. There were no other significant differences between the groups. This may be due to either unfamiliarity with the equipment or the lack of experience because the majority of the residents were in their second year of training. LMA insertion, direct laryngoscopy, and video laryngoscopy are all possible with a stereotactic head frame in situ. It took significantly longer to secure the airway using direct laryngoscopy and video laryngoscopy compared to LMA insertion. It took residents longer to secure the airway using video laryngoscopy when compared to fellows and consultants. Another alternative would be to remove the head frame instead of managing the airway with the head frame in situ during an airway emergency. However, this is also very time consuming. This study showed that the LMA is the quickest airway device to insert in the standard surgical position. Respectively, LMA placement, video laryngoscopy, and direct laryngoscopy averaged 39, 55, and 58 seconds in total. A physiologic model by Farmery suggests that, depending on various patient characteristics, including size and severity of illness, critical desaturation during apnea occurs in the range of 41 to 84 seconds on room air and 171 to 502 seconds if adequately pre-oxygenated. A second study by Tenzer et al. Showed that in post-operative spontaneously breathing patients with obstructive sleep apnea, the time taken to desaturate from an SpO2 of 92% to an SpO2 of 80 to 84% on room air was 2.6 minutes, and with 1 to 6 liters of supplemental oxygen was 4.6 minutes. By these numbers, an apneic patient on room air may critically desaturate before establishing a secure airway. Therefore, it might be important in these surgeries to use supplemental oxygen to afford extra time in case an airway emergency occurs. Some limitations of this study include the fact that the mannequin may not adequately represent the real patient at all times, such as the inability to produce cough, secretions, airway edema, and anatomical variations of the patient's airway. Also, the head frame location may vary. As seen in the photo on the slide, the nose piece of the head frame is in the down position, which is definitely not ideal when having to manage this patient's airway. Always ensure that the stereotactic frame's nose piece is in the up position prior to coming to the OR. Also, alternative methods of airway management were not considered in this study, for example, fiber optic intubation. Nevertheless, this is still an important attempt to improve the preparedness of the anesthesia personnel and to better equip them to deal with similar scenarios in real life. This study showed that both LMA insertion and tracheal intubation using direct and video laryngoscopy can be performed with a stereotactic headframe in situ. A laryngeal mask is the quickest airway device to insert and can be inserted while the mannequin is in the standard surgical position. Further studies are needed to validate the results in patients. Because my personal experience with this type of procedure and these types of patients is limited, I did ask around the department for some tips and tricks in dealing with these patients. The first thing that I came across was that there are a number of different masks available at LHSC, and a lot of them are very bulky and potentially difficult to fit under the stereotactic head frame. These are some of the masks we have available to us, including the Neurorounds mask, which is the red mask in the pictures on the slide. Unfortunately, these aren't the best angles to see the side profile of these masks, but ultimately, the red mask is definitely the one that is less bulky in terms of being able to fit under the stereotactic head frame and ultimately giving you the best seal for potential bag mask ventilation of your patient. If you have any concerns about the airway prior to the stereotactic head frame being applied, or if the mask does not fit under the stereotactic head frame, elective intubation prior to frame application helps in maintaining complete control of the airway. However, this requires transporting the patient intubated to CT and getting the frame placed and then transporting the patient back to the OR, which can be more time consuming as well as require more resources, but it's definitely the safest option for the patient. Therefore, it was suggested to see the patient in CT or MRI in the morning before the stereotactic head frame is placed and ensuring the mask fits underneath the frame. Another tip that I was told was to ensure that the tool used to remove the frame is nearby and know how to use it. If you are using the tool to remove the frame in an emergency scenario, there is a clamp that can be applied to keep the frame in the correct place. However, this cannot always be relied upon, particularly in an emergency scenario. It's probably best to secure the airway in this case and then transfer the patient back to CT to reapply the stereotactic head frame to ensure proper coordinates. So what happens if you are not able to see the patient prior to the stereotactic head frame being applied? For example, they are the second or third case of the day. The patient arrives to the OR with the stereotactic head frame in situ. I have created this simple algorithm to help with some decision making in this circumstance. The first question is to consider whether or not the mask will fit under the stereotactic head frame. If it does, and you believe that bag mask ventilation can be achieved in this patient if required, then proceed with the proposed procedure. On the other hand, if the mask does not fit under the stereotactic head frame, or you feel that you will not be able to adequately bag mask ventilate this patient, then consider an endoscopic intubation while keeping the patient spontaneously breathing. This is likely your safest option and most effective given the stereotactic head frame in situ. Thank you for coming to my talk. I look forward to reading your comments and answering any questions you may have about the material presented here today. Also, if you have any further information on this subject that you would like to discuss with me, feel free to contact me via my LHSC email at any time. These are my two dogs, Gus and Zoe, and they have been a huge help during this pandemic in particularly in keeping me sane and keeping me active. I hope you're all finding ways to stay safe and keep active during this difficult time. And here's a list of resources that I used for this talk. Thank you.